My name is Kate Payne, and I technically am called an Associate Professor of Nursing attached to the Center for Biomedical Ethics and Society here at Vanderbilt University Medical Center.
She's dedicated, she's open and honest and friendly and approachable, but does a lot of hard work for a lot of people, which is inspiring to see.
Well, she's a lot of fun to work with, but she's also extremely knowledgeable and has a lot of sort of clinical experience that gives her practical wisdom that I draw on frequently.
What my job actually is I work as an ethics consultant, which means I consult with doctors, nurses, anybody in the hospital, patients, families, to help them solve difficult problems in their health care.
Throughout the fall, I did my research here and talked to her a lot about just my thought process and writing papers and doing presentations, and she would offer her advice and allow me to practice with her. So she's a wonderful resource to have here.
About half or better of the questions we get asked are about end-of-life care. Like you're told that your grandmother isn't going to live and the doctors say we need to take her off life support and you have no idea how to even begin to think about that. We get involved in a lot of those kinds of conversations. Who's the person closest to you who'd be in the best position to make your medical decisions? Who knows me best, and will they really be able to do it? Because it's tough, right? Who wants to make a tough decision on the person you think is most precious to you? And a lot of us, you might be thinking, well, I'm not going to put my spouse on there because he or she, I don't want to burden them with that. I guarantee you your loved ones want to be burdened. Or at least you don't want to burden them, or we don't want to be burdened. But boy, am I going to be mad if Scott didn't put me on his. I'm going to be like, what's with that? What do you mean? And he might say, well, I didn't want to burden you. And I might say, what do you mean? I'm your wife. I'm supposed to be burdened. This is how it goes. This is what we sign up for. I have kind of a roundabout way that I got here. Originally in healthcare, I was a nurse. And then I worked at the Midwest Spine Trauma Center in Chicago. And I got really interested in people who had suffered broken necks or backs and were paralyzed. And, you know, like, could you be Christopher Reeve? And generally, when those people would come in, we would ignore what they wanted to do. A lot of them would say, I don't want to live like this, I don't want treatment, and we would just ignore them. And I couldn't believe that, because this is America, where what you say goes. But what the doctors and nurses were operating on was that it takes about 12 to 18 months for someone to shift in their head from being able-bodied to disabled. And so they wanted to give them that chance, and then if the patient wanted to refuse treatment after that period, then they would let them. So I got really interested in how we ignored someone's wishes, which led me to go to law school. So together, law, nursing, and medical ethics really fit nicely together, and so I've been doing that since 1994. What helps the patient and family, I think, is that because I'm not their family, I'm a person who's come to help in some way. I don't have all their fears and concerns and baggage, whatever goes into making them afraid to answer the question or ask the question, or they can't let their loved one go even though they know they wouldn't want this. I can ask those really tough questions because it's just different for me. And so I always try and be very clear and not get caught up in feeling sorry for people. What I really try to do is really empathize with them. I think, wow, if I was this person, how would I feel and what would I want to know? And so that's how I ask questions. I'll say to people, you know, if I was in your shoes, I might want to know this or that. Is that what you're feeling? And then if they say, no, it's not, then it opens the door for me to say, what are you feeling? What do you want to know? How could I help you? And really let them kind of guide me. Always you try to be compassionate and calm. The last thing they need is some other hysterical, overly emotional person. They need someone who can help them, if only to be there and listen. Sometimes I don't say anything. I just say, I'm just here to help, whatever you want. Sometimes I'll get them coffee and we'll just sit in the silence, which sometimes people just need to know that someone's there, that if they need someone, leave my phone number, stuff like that. So the
best parts about being in healthcare is the helping people part. The worst parts about being in healthcare is that people are really sick and dying, and so it just makes it really difficult business. But because it's something we choose to do, we accept that as just part and parcel of it. I think the really difficult thing is trying to make sure you don't get sort of overwhelmed by it, which is easy to do. Lose your boundaries and get overwhelmed by it. And I think when I was younger, that happened to me a lot. I just know that it fits for me. So it's interesting. I don't know. I think there was just something about it that resonated. And I was working in spine trauma, and so we had a lot of young men who'd broken their necks and were now paralyzed. And so that by itself is sort of a traumatic thing. And I think that's what prompted me to take a different path, to say, I want to know how to deal with this better. If you can offer someone some help along the way, that's a valuable thing to do. Because the frustration is not so much that nothing I know is working, but that I can't help them. That this is going to be a horrible situation because for whatever reason, nothing's working and they're not letting anyone in. And at some point, I find in those situations, you just have to say, well, it's not my life, and so all you can really do is offer to someone. And those are frustrating. Those are the ones that I think about that keep me up at night. But I'm pretty good at, like I said, leaving work at work so that it's not keeping me up at night.
But, so I think it's, even with all the work I've done, I think it's helpful, but we're really family as opposed to what I do for a job. It helps having all this knowledge, but it doesn't work the same in your own family, either fortunately or unfortunately. It's nice to have extra knowledge, but in the end, you're just a family, and you're still going to have to go through it like most families do, although I think for people with more information, it goes easier, as hard as it is. And that's sort of the one thing that especially when it's in your own family, no matter how much you know or how much preparation you do, it's still really hard for anybody. So I'm always mindful of that it no matter how smart someone is or how much they've prepared, they've got their medical directives and all that, when it comes to losing a loved one, it's just really hard. And growing up, so it's just really hard.
Yeah, I would agree, and again, I might be just repeating myself, but the fact is, for the last 20 to 25 years, I've had the opportunity to be prepared in a way that a lot of people don't, just by virtue of being with Kate and experiencing, sort of by osmosis, a certain aspect of understanding the context of these issues. Something that I never would have chosen to do, or probably would have stumbled into any kind of aspect of if we hadn't been together. Mm-hmm. I just can't even imagine how I would have gotten to that level of just having that kind of perspective on things about losing someone in your own family, especially. And also, I've lost friends too, and
That's true, Marty.
And just these last however many years, it's just become something that you have to accept. But also, again, just I definitely have a unique perspective that I'm grateful for, just based on. She's a friendly, intelligent, compassionate, wise person who cares about what she does.